Hey, good afternoon, everyone. My name is Kevin Corbett, and I have the privilege of serving as the CEO of the Oklahoma Healthcare Authority, and I also serve as the State Secretary of Health and Mental Health. Thank you each for being here today, and for those on Zoom, we appreciate you taking the time to come out and learn about what managed care is all about in Oklahoma, and we're really pleased for you to be here. I want to thank the Red River Technology Center here in Duncan. We love the hospitality. We really appreciate that. With us today, I have fellow Healthcare Authority colleagues and representatives from our health plans as well as our dental plans. Blue Cross and Blue Shield is here, Oklahoma Complete Health is here, Humana Healthy Horizons is here, and United Healthcare on the medical side. And our dental plans are represented here are DentaQuest, Liberty Dental, and MCA Dental as well. I want to also introduce one of our board members that you may know, I'm sure you do, is Tanya Case is here with us today. Longtime board member of the Healthcare Authority. I appreciate her attendance and support. So today I'm going to provide you with a brief overview of SoonerSelect, which is our new managed care program. And then we're going to open it up for question and answers. And after the meeting ends, as you can see behind me, we have many of the representatives from the health plans that you have the opportunity to visit with. And I hope you'll take an opportunity to ask them questions and get the answers to your questions. Let me start with some basics with regards to a managed care organization, oftentimes referred to as an MCO or a health plan. Is an insurance company that's responsible for coordinating health care services for our Medicaid members. MCOs provide whole person care in a home health models to support members in obtaining needed medical, dental, and behavioral health services, as well as referrals for all social services. As we know, social determinants of health make a huge difference in the health outcomes of our members. As you probably are aware, 40 states now partner with MCOs in some capacity in their Medicaid programs, and they have seen better results in quality improvement, access to care, cost predictability, and savings. Participation in the new SoonerSelect program will be based on a member's eligibility category and will include about 800,000 low-income parents, pregnant women, children, and adults, our new expansion population. What is not included at this moment is our age, blind, and disabled population, which is our very vulnerable population, and our tribal members have the opportunity to opt in to participate in our SoonerSelect program. It will begin on October 1, just around the corner. As you know, we've had lots of conversations about this, and that includes with the governor. Governor Stitt is dedicated to pursuing this program as one lever to improve population health in Oklahoma. And I think you would all agree that his support of this initiative is really unwavering. So all of us at the Healthcare Authority know how valuable the providers are to partner with and helping us serve Sooner Care. We have the very privilege of having over 70,000 providers serving our members currently today. And because of this dedication, we share to improve health for Oklahomans, and your expertise in your respective fields. We know that this approach did not occur without your input. And so providers and other stakeholders were involved in the design of our program, both from MCO and dental contracts. In fact, we had a process where we sought feedback and received over 100 responses to our public request that we launched back in July, and incorporated many of the recommendations throughout this process. You'll hear about many of those here in a minute. And continuing that spirit, we are holding this town hall today and several more in the future to continue listening to your questions and concerns and incorporating your recommendations as much as possible. We do hope you, the providers, will contract with every managed care organization that we have brought to the table to provide the greatest access to care for our Medicaid members in your community. So let me now start with an introduction of my teammates. They're going to make a few comments, and then we'll turn it over for questions and answers. So let me start with Melody Anthony, who is our State Medicaid Director as well as our Chief Operating Officer. Right next to her is Trey Lorraines. He is our Deputy State Medicaid Director. Aaron Morris, who is our CFO. Dr. Karen Luce, who is our Director of Dental. Dr. Terry Cothman, who is our Pharmacy Director. Dr. Mike, you there? There's Mike Herndon, who's our Chief Medical Officer, and Dr. Nathan Valentine, who is our newly appointed Chief Quality Officer. So let me now turn it over to Melody to make some comments with regards to what this managed care program is all about, what it means for the providers, and it's really about the what for you to have the opportunity to understand how this is going to work for you and your patients. So Melody, if you take it up.
Good afternoon, everyone. I'm happy to be here. As Kevin was saying, we are moving into a new delivery system called SoonerSelect, which is a Medicaid managed care option for us to work with plans to make sure that members receive all the services they need, timely, medically appropriate. And the only way that we can do that is if we have the provider network that we need in order to support the 800,000 people that will be part of this program. So as we were going through our due diligence and our stakeholder meeting, we actually were able to put into the RFP some what we call guardrails, which protects the provider community. And when we talk about guardrails, we talk about, we put in claims payment within 14 days, prior authorization within a specific turnaround time based off of the prior authorization that is being requested. We worked with providers to make sure that they were aware of our current fee schedule and that they understood the importance of our fee schedule, but we also allowed the providers and the health plans to be innovative on how they care coordinate and pay for the services that the members need. So and we also put in some criteria to make sure that the provider is heard when they have challenges with the health plan. And we also put in some criteria for a member who has challenges with a health plan. So on the provider side, they can actually talk to the health plan about, I don't believe my referral or my PA was handled appropriately. And they work through with the liaison between the health plan and the provider office, because they have provider relations staff as well. If that is not a resolution that is satisfactory to the provider community, because they are still our providers, they can come to us. And we are an advocate for both the plans and the providers, but we want to make sure that the decision is made appropriately for both parties. The other thing we have is if a member has a service or is denied a service that they feel is inappropriate, the member first, again, has to go to their health plan. But if that resolution is not satisfactory to the member, again, we are the person that they come to. And we have what they call a fair hearing process that the member will go through in order to get resolution. So we will track those on a monthly basis. They have reports that we will see from the health plans. Every time they pay a claim, we know what that claim was paid for and how much. Every time they deny a claim, we know what the denial was and why. So we have an internal operating and reporting area that their entire function is to make sure that the services that we provide today are the services that our health plan providers do in the future, and the health plans have the luxury of adding more services than we can provide as Medicaid, because federal government allows the managed care organizations to have more flexibility in servicing the members that we serve today. So we also have some specialty initiatives going on, and I'm going to let Traylor talk about those to give you a little bit more overview of some more details about behavioral health, tribal, dental, our children's specialty plan, things that we think are unique to this new delivery system.
Thanks, Melody. Again, thanks everyone for coming and joining us today. So to piggyback off of what Mel mentioned, we do have something I'm personally excited about is the children's specialty plan. So Oklahoma Complete Health will be the single vendor that will offer a statewide solution for all of our kiddos in the custody of child welfare, the juvenile affairs division within the state, to really wrap care around these kids who traditionally have relied upon their DHS caseworkers to manage every aspect of their care along with foster parents. This way, they'll have a single point of contact through a care manager within Oklahoma Complete's plan that will follow them statewide. We know a lot of our child welfare kiddos travel a lot. They're placed, so, you know, they could be in Ardmore one day and Guyman the next day, but this way they have one person that can coordinate and help them access behavioral health care, specialty care, and primary medical care wherever they go. We've worked closely with Deborah Shropshire, Dr. Shropshire at the Department of Human Services in developing that plan, and we're super excited about that. In addition, we have new opportunities within our behavioral health delivery system. We do recognize the current fee schedule for our behavioral health providers is not where we'd love it to be, but it's where it's at because of budget shortfalls throughout the last few years. And we recognize we don't want our managed care partners going any lower than that. So we did preserve as a floor our current behavioral health fee schedule that our managed care partners will use as a starting point for rates with our behavioral health providers. There's also more opportunities for integrated care and primary care settings through independent licensed behavioral health professionals through the managed care delivery system that is not currently available through SoonerCare as we know it today. I just want to also point out for our tribal partners that may be in the room or listening, we did work closely with our tribes and our tribal partners as we went through this process and listened to their feedback. We have, as a lot of you may know, we get 100% federal reimbursement for certain American Indian, Alaska Native individuals that seek care through a tribal facility, and we want to preserve that. And so if an Alaskan Native American Indian individual seeks care at an Indian healthcare provider, they will continue to get 100% reimbursement. And regardless of whether that individual is enrolled in a plan or not, they'll continue to bill the healthcare authority directly. So it doesn't require them to go through a plan for that. Now, there are times when a facility may serve a non-tribal member that is aligned with an MCO. They would need to build a plan then, whether or not they're contracted or an in or out of network provider. But I will say, just to echo Melody's comments, in drafting this RFP, which was roughly 500 pages plus, we took everything we have learned from the Medicaid program the last 20, 25 years, incorporated that knowledge. We know what we want from our partners. This is not us handing over the wheel to new organizations to manage the benefit. We'll continue to monitor compliance with the hundreds and hundreds of weekly, monthly, annual reports that they'll have to submit to us. So we're really excited for the opportunity and really just see this as an extension of the good work we're doing today.
And Melody, we do have a summary of kind of the key provisions of the contract available to anyone here in the room that would like a copy of that, I believe. So. All right, let me ask Melissa Ritchie to come up. This is our Chief of Communications. She's going to moderate the Q&A both here in the room as well as on Zoom. And then I'll hand it to you.
Thank you. We will now open the floor to questions for our panelists. Please keep the mic that's right here on the second row. We will alternate between our viewers and our virtual audience.
Good afternoon. I'm a pediatric occupational therapist with 23 years working with children with special needs and developmental delays. We know that 1 in every 33 babies born in Oklahoma will have a birth defect. In the US, 1 in 54 births will be diagnosed with autism. Pediatric OT, PT, and speech therapy are vital services to preventing long-term disability and improving health outcomes. The cost of lifelong care can be reduced by 2/3 with early diagnosis and intervention. We are on the front lines teaching kids to walk, talk, and live independent lives. In Oklahoma, pediatric therapy services are already stretched thin. There are already limited providers, especially in rural areas. One of my greatest concerns is that there will be loss of therapy providers with the change of managed care, impacting services that children with special needs and developmental delays will have access to. This will greatly increase the cost of care for the state of Oklahoma for these children once they reach adulthood. So what is the benefit of MCOs for children with special needs and therapy services? And what is the timeline for moving from primary care case management to value-based payment? And will reimbursement rates include multiple procedure payment reduction, where if we see a child for multiple services in a day, the first service will be reimbursed at 100%, and the next service at 80%, and the next service at, say, 60%? How does that increase and improve quality of care for our recipients who would have to come and make multiple trips to a clinic during a week in order for this to be cost effective for the therapy provider?
And thank you for the question. So I'll take it kind of part by part. I will start by saying we completely agree with all of your points and your concerns, and we share those concerns, of course, for our population and the members we serve and the providers who serve them. What I would start with is just reiterating. So for our children with needs that actually have to qualify them as disabled, they will not go into managed care. So they will continue to get services the way they currently do today. For those children that are not qualified as disabled but need extra support, we actually feel that by bringing in our managed care partners, we're going to be able to identify a lot more of those kiddos earlier than we currently do today through early intervention, through health risk screenings. So one thing that we do well as the healthcare authority is care coordination, but we're only able to do that for a small portion of our most medically frail individuals through certain waiver initiatives, health management initiatives. We have great examples. One was our member moment at our board last couple of weeks ago. The thing is, we have 96 people in that one program that we're able to care manage. By bringing in 4 partners to manage just the medical piece, there will be required health screenings at intake. They'll be able to identify a lot of these issues that it takes families years to realize was even an issue with their child. So we feel by going through this process, we'll be able to get them to your door a lot sooner. So you can provide the great work you're doing now ahead of the curve and actually prevent a lot of the behaviors that are exacerbated by the time they get to your door. I will also say in terms of reimbursement, our success is dependent upon our managed care partner success, which means you need to be successful as a provider. That means they have to have an adequate network, and we have specific requirements around time and distance standards from where our members live. There has to be providers and specialists, and we won't allow them to move forward. The term for us is readiness. We won't consider them ready if they don't have a fully complete, adequate network of all of our currently contracted provider types. If they don't have that, if they're not ready, CMS won't allow them to move forward, nor will we. And to get that adequate network, they're going to have to reimburse adequately. So we're not expecting to see slashing of provider rates or making it harder for members to access care, because then the client's not successful, you're not successful, and they're not successful. So we will be on top of that, monitoring it. We're going to receive that information reports, denial of PA levels, stuff like that. We have teams that will be dedicated to researching and monitoring that. So I think I addressed all the questions, but if not, happy to chat after too.
Okay, we'll go ahead and ask our first virtual question. And we're seeing this being asked multiple times. So I know we have addressed it, but we're going to address it one more time. How do we obtain contracts with all 4 plans? That's the first question. I'll have you answer that one first.
Great question. So I will say on the Healthcare Authority on our website, oklahoma.gov/OHCA, we have an entire page dedicated to the SoonerSelect program. On that page, we have contact information for all of our providers, both medical and dental. I encourage you to reach out individually using their 800 numbers, their email addresses that they've set up. If you aren't having success getting through, or you feel like your questions aren't being answered by the plans, please feel free to reach out to Amy Broad's group and Provider Services using the regular call tree that you're all accustomed to, and we will take care of that. I have daily emails and conversations with the CEOs of the various plans, and even if an 800 number is down, I'm emailing them saying, fix it. So I would say reach out to them, contract with them. All of our plans are working together to make sure that the enrollment process is as easy, efficient, and streamlined as possible. And so even though they're all competitors, they're coming together to make sure that the process is easy for our providers, which we really appreciate.
The follow-up to that question is, if we are accepted by 2 of them, but not the other 2, what happens to our clients that choose another plan, especially if they want to keep receiving services from us?
So I would say most chances are, if you've applied to contract with a plan, they're going to accept you in most cases. But if not, that client still wants to maintain their care with you, you would just be considered an out-of-network provider. Reimbursement may be a little different from an in-network provider, but it would work similarly to private health and insurance carriers.
Feel free to come up to the microphone whenever you're ready to ask your question. Will private insurances pay for assessments or intakes?
I come from the behavioral health world, so I'm going to assume that's a behavioral health agency question. Again, I'll reiterate the term private. So there's difference in commercial healthcare, which is not Sooner Care, and then our new SoonerSelect Managed Care Partners, which is still an extension of Sooner Care. But I will say yes. So again, if it's behavioral health related, assessments and intake is done. It will continue to be reimbursed for. Like I mentioned earlier, behavioral health fee schedule is actually preserved as a floor as to what it currently is today.
I think it's important to recognize that our current benefits are kind of the foundation of this plan. They cannot be deleted, if you will, or declined on those bases. So those services stay intact.
That's a great point, and we're actually working on a benefit comparison guide currently, a partnership between the Healthcare Authority and all the plans to talk about what the benefits are among each plans, and then give them the opportunity to say within their piece, what value are we adding to the state by offering additional benefits. So we expect that to be ready within the next few weeks. That will also post to our website.
Hi, everyone. Good to
Hello,
see
Jay.
all of you. I'm Jay Johnson. I'm the president and CEO at DRH Health here locally. Appreciate you coming to Duncan. It made it a lot easier to attend this kind of a meeting today.
Glad to be here.
Yeah, thank you. I've got a couple of questions for you. One of the things that we worry a lot about at our hospital and really all of our hospitals across the state is this projection of the 40% reduction in utilization. A 40% reduction is pretty detrimental to our hospital's operations. And so if the plan is to reduce utilization by 40%, how do we do that? Especially when you consider most of our hospitals are comprised of pregnant women and children from a utilization perspective. And then secondly, I wanted to ask about the 340B drug program. Our hospital is pretty dependent on this program, and it's a significant reduction if we're not able to maintain our number of Medicaid inpatient days. So how do we make up that loss of revenue? Thank you.
Aaron, I may take the first part of that, and then you can chime in. So what you're referring to is the 40% assumption that was made in the determination and development of the capitation rates that we're paying our partners, if you will. Good? Okay. So it is an assumption. It's an actuarial assumption for purposes of rate setting. Those assumptions have been built off of a series of empirical data points that our actuaries utilized, including other state experiences when this transition occurred. What I want to make sure that everybody understands is we're really talking about the redistribution of care services. We're not talking about a reduction of services for a member. It's just a different type of service because this is mainly built on the basis of a prevention model, a coordination of care. And so to the extent that we can have early intervention, early prevention, the opportunity to, as you would probably agree, to reduce the level of kind of non-emergent services being performed in emergent situations like an emergency room or a hospital. So I think what you're going to see is a redistribution of how care is utilized by our membership to drive both a outcome that is much more desired than we have today, as well as some level of more efficient use of the system itself. But again, those are primarily simply for rate setting and not necessarily our view of how actual services will be distributed or actual service will be rendered. We're not going to decline a service, and the MCOs won't decline a service as medically necessary at wherever it needs to be performed. And we'll be monitoring the denial rates, the PA turnaround times, and things of that nature. So, I believe that's okay. Go ahead.
Yeah, thanks for the question, Jay. And just my comments, Jay. We talked at the beginning of the public health emergency, and you shared some data with me that I actually used for our budgeting. So know your interest in your investment in your members and your patients, and really appreciate our partnership as well. So I reiterate what Kevin said. This is a high level estimate, and you're talking about a single assumption in a multitude of assumptions. So there's an assumption for that, but there's also built-in assumptions for distribution of spend based on population. So 40% isn't across the board. That's a, you know, it's again, we're pulling out a single assumption, which is difficult to do in an actuarial process. The, you know, the goal of the rate setting is to provide a reasonable and appropriate rate to pay managed care organizations to manage our members and pay those claims. How they get to the point and live within those means is, you know, it's kind of on them, you know, that we're relying on their expertise to do that. So the redistribution of spend that Kevin mentioned can come from a multitude of ways, whether that's, you know, a focus on primary and preventative care, or a focus on social determinants. It may not be, we may not achieve 40% reduction in inpatient hospital services, especially across the board, and it may be different from one hospital to the next. So I think it is really important to understand that, you know, we want to shift from a payment based on volume to a payment based on value. And our partners are going to help us get there. So if you guys render a service to our members, and that service is appropriate, medically necessary, the claim will be paid, and it's our responsibility to ensure that and provide oversight. So just again, what Kevin said is right on the money, and happy to have, you know, further discussion on that point.
Do you want to address the 340B question?
Yeah, so 340B, that's a common question that we've received. It's one that's a little more out of our line of sight. You know, it's not our program, it's a federal program. But we do understand that Medicaid plays a role in that. The eligibility is derived from, you know, the Medicaid business as a portion of the total business. And, you know, I would say that we understand that it is a concern. We want to, you know, help our hospitals to continue to receive the funding they need. And we also, you know, want to make sure that we're transparent with the process. So with 340B, hopefully the expansion population will help there moving into Medicaid. You know, but our goal again is to provide or pay for appropriate services. Our goal, whether we were to go managed care or not, would be to kind of shift the distribution of spend away from higher cost, lower value services to high value, lower cost services. Hopefully that's a focus on primary and preventative care. And ideally, you know, all the hospitals still qualify for 340B that qualify today. It's just a little bit of outside of our line of sight on the data. I mean, I can kind of model that, you know, with the information I have. Difficult to tell who's on that line that could be impacted, but we do understand it's a concern. Yeah, and Jay, does the expansion change from, you know, uncompensated to moving in? I know it impacts the 40% as we talk about, but does it? Sure. So, Jay, yeah, reach out anytime. Happy to have a conversation, and thanks for the question.
Hi, my name is Christy Spencer. I'm the clinical director at Bridges Behavioral Health. We're a partial hospitalization program for adolescents. And currently we work with a lot of SoonerCare clients, and the approval process has been that we do an assessment and determine whether or not they're appropriate to receive treatment. Through SoonerCare, we, in our note system, we input the CDC, SoonerCare makes the approval. But we've had tremendous difficulty with private insurance companies getting approval. So where SoonerCare does a 3-month approval, private insurance companies are deciding whether or not the kiddos can stay 2 days, 3 days, then call us back, tell us what the progress is. And then maybe they want to downgrade to IOP services. So we haven't had much luck with private insurance companies. How will the pre-authorization process work with 4 different partners moving forward? Thank you.
Great question. So I would say to our plan administrators in the room, talk to her after this because you're going to need PHP providers. We only have a few of you in the state, so we appreciate the services you provide. Great question on the CDC. So in developing the RFP specifically around behavioral health services, we're requiring that they continue to use the CDC because A, our providers know how to use it and it's comfortable and familiar, and B, we get a lot of valuable statewide information for all of our clients that we use, the Department of Mental Health uses. So we wanted to maintain that process. So the main difference then is that information and the clinical information will now go to one of our 4 plans, whoever is covering that individual kiddo. And then we'll use a process very similar to what we use today, using very similar medical necessity criteria. And talking with the plans, they all use, I think, either one of 2 different nationally recognized medical necessity criteria companies. I will say, from my understanding of commercial insurance products, that PHP is not widely understood or accepted by most carriers. So Medicaid, SoonerCare is unique in that, but it's built into our policy. It's required service within the RFP that the plans provide that. We also have very strict criteria about, we require the kid to go at least 4 or 5 days a week. So they would have to go by that as well. Current PA guidelines, turnaround times, criteria will be very similar, if not the same, of what we're using now. All the plans will have to submit their criteria as well as prior authorization processes to the healthcare authority for approval before they implement as well. So I would say that we value that program. Again, there are so few of you that we need to get kiddos through your doors. So we will work with our plans to make sure that you are successful moving forward.
Does that mean that as of right now, you don't have the information as to how each one is going to do it when you say they need to submit it before the plans to before? So we're not really sure what that's going to look like moving forward.
We do for the most part, but what I guess I'm trying to say is they're not going to slip us a surprise and like starting to deny a whole lot of PHP because they've added in something really strict into the criteria. We will have reviewed all that. They submitted within their responses, their overall processes. When I say responses to our RFP, our request for proposal, their overall processes for authorizing various services and turnaround times and stuff like that. But they will actually give us the actual medical necessity criteria that they use in the various DSM-5 and ICD-10 that they use to approve. So before that goes into effect, we'll have it approved, all that.
And then one last thing, I know a lot of people have questions. Will we continue to use the CDC, but will we still do it through one place, or will we need 4 separate systems to do that?
Yeah, it'll be separate. And it could be, if you're seeing someone that is a kiddo, for example, that's age or that's disabled, you'll still go through the PISIS portal, through the DMH portal for authorization. The others, though, the plans will have their separate portals, but they'll have provider reps that can help you walk through all that and get you up to speed on that. Unfortunately, that it's going to be a little more administratively burdensome. We understand, but I also know they're going to make it as easy as possible for you to get the administrative piece done. They're probably going to ask you to come to the mic. Thank you.
Say if you have a consumer that's with a CMO, and that consumer now develop SDI type of issues, is the transition going to be smooth going from CMO to a traditional Medicaid, or will they stay where they are, or will they transition? You understand what I'm asking?
So let me see if I understand the question. Are you talking about when someone would go from a managed care entity, let's say they become terminally disabled and they come back to healthcare authority?
Right.
Yes, we built in protections within the RFP on what that transition looks like. There's an expectation that they'll continue to provide care or reimburse for care while they're under the managed care entity's service delivery, and then transition them back to us so that it will be seamless.
So, and then another question I want to ask, will it be more of a unified traditionally technique between all 4? So it looks kind of the same to all the providers who's trying to get credentialed with every
Yes, and I touched on that earlier. So I will say your first step will still be to come through the Healthcare Authority. So you'll submit an application to the Healthcare Authority, get enrolled through provider enrollment. We'll do all the screenings and stuff like that. Well, then our plans will pick from that bucket of providers who have already gone through our process. There'll be another credentialing step, but that's what I mentioned earlier. Our plans are working together to make sure that is as easy and efficient to use as possible so that they're not all asking various different questions, that they'll make it as streamlined as possible. And they are working together to make sure that that's accomplished before we go live. So it'll look very similar. And we are required to use a uniform credentialing application that the health department creates. So there's that as well.
Just a quick reminder for those that are in the room, if you would bring your follow-up questions up to the mic so our virtual audience can hear your question, that would be great. You've mentioned medical and dental. What is the plan on pharmacy benefits?
Well, that's pretty broad, but as Kevin mentioned, these are just an extension of what we currently do today. So our pharmacy benefits are set up in a manner that will mimic what we do today. So as far as reimbursement and things like that, there really shouldn't be a change or shouldn't see a change in that. So I would expect from the pharmacy world it to look very similar, besides just maybe having to contract with an outside plan.
My name is Kelsey Lee, and I'm representing a pharmacy out of Davis, Oklahoma. Do you know if the plans will have DIR fees?
We have in our agreement that would not be allowed.
Okay. And also, the state of Ohio is suing Centene, sorry. She talked about, I guess, safeguards earlier. In Ohio, they billed for what was already paid. Will that show up as well, or how do we know overbilling isn't going to occur again?
We are aware of that. I know there's an ongoing lawsuit. Obviously, we'll keep an eye on that and see how that plays out. And then it's kind of lists some details, as you said there, of what happened. So that would definitely alert us to pay attention to that and prevent that here.
Okay, thank you.
If OHCA assigns a member to an MCO, will OHCA check that their current provider is in network with that MCO, since OHCA knows their current preferred provider for most members?
Remember to take my mask off this time. Great question. So I'll just kind of give a quick run through the enrollment process and what it's going to look like. So around July 1st, we're going to start sending out notices to our members that will be eligible for the SoonerSelect service delivery system, letting them know that effective October 1st, we're going to have a new way of delivering your care. We're going to have 4 medical, 3 dental plans, and a specialty plan for you to choose from. And then we will have our call center ready and trained to do what we call choice counseling. So members will be directed to call our member services hotline. We can walk them through that. That's when that benefit comparison guide will come in handy, because we can walk a member through that, direct them to our website to see it visually. And then we can also, look them up in the system. And at that point, we will have required our plans to create or recruit an adequate network at that point. So we would know which PCPs and specialists are aligned with each plan so that we can do exactly that. If a member has not made that choice on their own, by September the 14th, we will do an auto assignment algorithm, which is a very basic round robin algorithm to the various plans until everyone that's eligible for SoonerSelect has been assigned to a plan. That doesn't mean they're stuck there though. So let's say a member then gets a letter saying you have been designated or auto assigned to Humana, for example. They look it up and they say, well, my PCP is not in their network. They have 90 days from that point to then call us or go online, make a change of provider, or a plan so that they can remain aligned with their provider. Again, reiterating, if they're not in their network or contracted, there's still an opportunity for them to be paid as an out-of-network provider, even if they're not in their network. So there will be lots of choice counseling as we work with our members and helping them make the best decision and plans to choose.
Hello. My name is Dr. Chris Valero. I'm a pediatric dentist from Lawton, Oklahoma, board certified. I have 3 associates with me who are also board certified pediatric dentists, and we are the only board certified pediatric dentist for 50 miles any direction. Wichita Falls, north to Oklahoma City, east to Duncan, west past Altus. We see 100 Medicaid children every day, and most of those are severely poorly taken care of. They have high dental needs, rampant dental caries, many of which have seen plenty of providers prior to seeing our office. So they're referred from pediatricians, other general dentists, other providers around the area. They come to our office where we provide dental sedation, treatment under general anesthesia, sometimes emergency care. And we do this on a daily basis, certainly not to make money, because at the current rates, it's barely breaking even. So from a personal level, I just wanted to share that if there are fee reductions or increased administrative burdens that lead to our office having difficulty, from my perspective, we will not be able to continue to serve those children. And if we're not available to do that, like I said, I don't know who will within a 50-mile direction. With that said, I'd like to speak on behalf of the ODA, the Oklahoma Dental Association, and they strongly oppose the move to managed care for dental Medicaid. They've got a few talking points, and I'll just throw a couple out there, but in the past, the state has attempted this sort of move before, and it didn't go very well. Certainly according from the dental perspective, 90% of the Oklahoma dentists who provided Medicaid dropped out of the program. And that maybe have been related to the reduction in fees, maybe increased administrative burden. You guys can probably speak to that better than I can. But the big concern forwards is that currently we run at a 5% expense, and these private parties that want to manage Medicaid admittedly run at near a 15% expense level. Somewhere there's got to be some ability to make up for that expense change. And in our opinion, it's either going to come through denial of services, denial of prior authorizations, or just difficulty in the office and the provider's ability to be reimbursed for the needed services. So I know that's a big question there, but we'd like to just know what safeguards are in place to prevent some of these issues. And as a practicing pediatric dentist who sees these kiddos on a daily basis, if we're not the ones seeing them and they wind up in an emergency room, how does that help the underserved and benefit the program? So thank you, guys.
So I'll address a couple of your concerns, and Dr. Luce, if you want to jump in a second. So what I would say is, as you were talking, and completely agree with your points, I'm going to circle back to what I mentioned earlier with when we look at the geo-access mapping for dentists in this area and the west side, they need dentists to provide adequate network services to our clients. So to do that, again, you have to reimburse adequately. Something I heard in what you mentioned was kiddos that you're getting or providing services to that have been to multiple dentists before you. So I'm seeing a lot of costs that probably should have been avoided and aligning them with your practice to begin with. So through managing care, through a managed care entity like this, there's going to be value-based payment opportunities, performance-based payment opportunities. So we are getting those good providers reimbursed properly rather than sending them through 3 or 4 providers that didn't really take care of the issues to begin with. On the other pieces, I would say that from a federal regulatory and state regulatory perspective, managed care is nowhere near the same as it was 25 years ago. Medicaid, CMS has come out with so many regulations since then, which is where we've done a lot of our lessons when we drafted the RFP. So there's a lot more oversight this time. It was also different. We have a statewide solution this time. Back in the 90s, it was, managed care companies manage the metro areas. Rural fell to the healthcare authority. It was very disjointed. And we're using all those lessons learned from the 90s, early 2000s to really not make the same mistakes twice.
Thank you so much for your service. I just want to reiterate everything Traylor said, but also add that, again, I think the benefits are great by doing this plan to improve outcomes. We're going to get these kids to your office first as a dental home, and we're going to see much greater preventive care so that we don't have all that extensive work. So that's our goal.
And just real quick on your last point, it's a federal regulation at a maximum of 15%. That's certainly not what we are anticipating or expecting. So I understand where that point comes from. It's just not our expectation.
And what I'm seeing too, that a lot of these plans aren't talking about or bragging about it from themselves, from their perspectives, is we're already seeing a lot of investments in rural health initiatives that are not required as part of being a managed care entity in SoonerSelect, but they're giving donations through Public Health Institute to get to rural communities. They're investing in our local communities and investing in health initiatives that aren't part of the everyday treatment and prevention services that they're actually required to do. So I think there's a lot of opportunity in that space as well.
Yeah, and I might make a comment. This has been our underlying premise all along, is that we are all about outcomes and outcomes for the state. Our vision at the Healthcare Authority is for all Oklahomans to be healthy and have access to quality healthcare regardless of the ability to pay. You've heard Governor Stitt say many times he wants us to be a top 10 state. We are far from it when it comes to healthcare and health outcomes. In our world, we have the opportunity to serve 1 million individuals and try to do something about the health outcomes, at least for that population. So we are trying to partner with all the experts we have available to us to make that happen. We know it's a daunting task. We know it's a long drive, but the time is now. We've been at this for a long time and not made really much of an improvement on health outcomes for Oklahoma. There's a lot to that to unpack, but we believe that we owe an obligation to the state of Oklahoma for this population to be a contributor to outcome improvement, and that's really what's driving us here. And trying to have the best delivery system that really does salute and honor that. So.
Hopefully I'll be less nervous this time. I just wanted to make some comments on some of the providers. I've done some calling this past week. And first of all, I just want to say I appreciate that OHCA is a timely payer. I think besides TRICARE, I think Medicaid reimburses very quickly. The call center is excellent. We can get policy questions answered, claims questions answered, TPL questions answered. It all works pretty well. It's paperwork heavy, but we do it. We make it work. My concern is the increased admin time is going to take with managed care. Increased admin time takes away time that we would spend with the recipients and families. And it's a big concern of mine. So this is my experience so far. I don't know if you can hear me. United Care usually takes about 3 to 6 months for claims to process as a primary. That's a long time. Right now the phone number on the OHCA website is a non-working number. You call them, you get another number, and you get a computer directory, and I just got stuck in it. I couldn't get anywhere. I couldn't get to a human. I just gave up. But how are they going to, I have my doubts that they're going to pay in 14 days when they pay through their other program in 3 to 6 months. Humana, I was sent to a call center in the Philippines, and I was told there was nothing set up for Oklahoma. I would have to be signed up to be a provider in order to see the fee schedule. And in Oklahoma Complete Health, they have told us already for therapy that they're going to reimburse at 20% of the current OHCA rates. So under their program, you're asking, this is for pediatrics, to do an OT or PT evaluation for $52. It takes an hour. We only can spend an hour with the child. It's 2 to 3 hours of paperwork after that's done. I don't see how those numbers can even work. I just don't. I'm very sad for that, and I'm sad for the kids that we serve, because we are one of the only providers in Southwest Oklahoma, and I'm sad because we see hundreds of kids in our clinic every week for therapy, and there's no therapy in the early intervention system in Comanche County, Caddo, Kiowa. I'm very deeply concerned that these kids are going to go without what they need, and I don't know what we can do about that.
So I hear your fears. I definitely sense there's fear in a lot of the rooms that we talk to and a lot of the folks that I talk to about these exact same topics. What I will say is, we've talked to our managed care partners about the rates, and they all agree that our rates schedule the way it is great, and they are working to reimburse at that level. On the 14-day deal, that was one of the lessons learned from the first time we did managed care. Was 45 days maybe the federal limit, but that doesn't keep our providers' doors open. So that's when we actually went to paying weekly at the time, because we needed more providers in our network, and we learned that. And that's, a lot of providers have several payer lines that they work with, but they depend on SoonerCare to pay them every week to keep their staff paid. And we totally get that, which is why we required 14 days in the contract. I will say, if they don't pay timely, there are liquidated damages that we can assess per claim not paid timely. And so when you start adding that up per claim not paid, that's a lot of money they're going to have to pay us if their claim is not paid within 14 days. Again, so many reports that we'll be pouring through and have teams dedicated to monitoring this. We've worked with consultants nationwide that are helping us to really focus on, these are the reports you want to look at now. These are the reports you want to look at October 1st when you go live, and then the months thereafter. And that's really one of them, making sure that our call centers are available to our members and providers, as well as timely payment. I will say I hear you on the numbers and the websites, and I have sent emails and texts and calls to every plan administrator in this room when that happens, and then require resolution pretty quickly. So we don't want you to be frustrated by that. And working with our partners, just since they were awarded March 1st, they've been very resolute in getting responses quickly. We don't want you having to go through that hassle. And I would say they're all in this room, so please step by their table after this and let them know exactly the experiences you've had, so that they can get that fixed.
I will make a comment. We took great efforts to draft a contract that put all the guardrails that Trailer's talking about. We're also in the process right now to making sure that the process, both at the plans as well as at the healthcare authority, are capable of administering those contracts. So we're in the development stage right now of all of that. Things are still being developed, being worked through, both on our side as well as on the health plan side. We'll evaluate all of their processes before we allow them to launch. That's the readiness review that Trailer's talked about. At the same time, it's important to recognize is that we're responsible for the Medicaid program in Oklahoma, that being the healthcare authority. These plans are our partners. They're assisting us in executing our responsibility, but we're not transferring that responsibility to them. So whatever the plans develop, it is and execute, it's on us. And so we are developing the processes and the monitoring capabilities to ensure all of our expectations are met. That may not have been what the situation was 20 years ago. That certainly is not what takes place oftentimes in commercial, as even Medicare as well. You don't have someone like the healthcare authority as the ultimate responsible party, making sure that all the expectations are fulfilled. That's our role, and that's what we're working day in and day out to build that process to ensure you all that if there is something that goes wrong, and inevitably something will go wrong in a small way, that we identify it timely and we resolve it timely. That's our role and that's our commitment.
Will the claims process for submitting claims be streamlined between the different managed care partners, similar to the way it is currently set up with SoonerCare? This is a common question that we're seeing too, so if we want to spend some time on this.
Sure. So each of the plans will have their own provider portals and member-facing portals. So for billing, if you have a Humana client, you'll go through a Humana provider-facing portal to submit your claims. If you see an age-blind disabled client, you'll go through your current provider portal now. Or if you are a provider that works with an EDI vendor, they will set up connections with all of the various plans in order to get those claims submitted for you.
This will be our last question virtually. So if there's anybody else in the room that would like to ask a question, please come up after this and then we'll wrap things up. I believe this is more for our partners, but I'm going to bring it to the panel just in case. Will there be a workshop to help providers who are new to billing private insurance? We would like some help.
I would guess that each of our plans will have a lot of technical assistance and provider relations interactions with you as we go through this process so that everyone is ready to go and successful with submitting claims beginning 10/1. But yeah, that would be a question.
Yeah, and I agree with that. And there are requirements in the contract that for training materials and trainings for billing purposes. So again, yeah, get with your plans, and they'll have that opportunity to train you as well.
Hello, Chad Scott. I'm a local pharmacist. Question on prior authorizations come October 1st. I'm assuming those are all going to roll over. Say a brand name ADD drug is approved. The Blue Cross Blue Shield or Humana, whoever, that's all still going to be honored, and not real sure about that.
Now?
Yep.
Yeah, my understanding from our discussions with the plans is when we transition members over, they'll get the last, say, 100 days or years worth of data that's already in place. So prior auths, things that are already in the system, will go straight to their system, so there shouldn't be a disruption or a gap on those. Is that what you were asking, or is there more to it?
That and when there's a brand name required as opposed to a generic, as far as Medicaid requires.
Right.
Is that still going to be the case?
That will still be a potential. They're going to follow our preferred drug list and formulary like we have it set up today. And all 4 plans will mirror that. So what you're used to and seeing from a Medicaid standpoint will look very similar, if not exactly the same as it does today.
Excellent. Thanks.
That went fast. Well, we're going to stay around if you have any further questions and you have the opportunity to visit with the plans. Do appreciate you all participating. All the questions that came in on a virtual, we'll capture those and provide those. Also, I want you to be aware that we're going to be hosting a number of other town halls. Next one is on April 7th in Poto, Oklahoma. We'll still do a website and a virtual showing of that. So if you have some questions that you wanted to ask and didn't get asked today, we'll certainly take those at that time. I want you to take the opportunity to visit with the plans that are here. I want you to get to know them, understand their operations, because they are our partners. They're accountable to us, but they're your partners as well. And I want you to be happy with what you have to hear from them about. If you have additional questions, you can also submit those through our website. Certainly go to oklahoma.gov/OHCA, click on today's town hall, and we'll take those and respond back to you. But again, thank you so much for being here. I know this is a big journey that we're all on. I can tell you at the Healthcare Authority, we are all committed to making this successful. I know our board is committed to that as well. This is a big move for us. I mean, we have the opportunity to change the direction of health outcomes in Oklahoma. And certainly the Healthcare Authority wants to be a big part of that. 1 million individuals that we have the opportunity to serve, some of the most vulnerable in the state, as you well know. This is our chance. And so that's why we're doing this, is that we really want to change the direction. And we hope you will be a part of it as well. So thank you very much.